My name's Lisa. I'm one of the fourth year medics, and today I'll be giving a revision lecture on endocrinology. So, for first year, you need to know about the pituitary, the thyroid, the parathyroids, the adrenal glands, the pancreas, and gastrointestinal hormones. And you'll also be expected to incorporate experimental evidence and clinical things as well. So in my slides, just for your reference, I've put evidence in purple and clinical things in pink. So what is a hormone? A hormone is a chemical messenger released from one cell to influence the activity of another cell or the same cell by activating a receptor. And hormones can travel in the blood, in which case they're endocrine, or they can be released into the extracellular fluid, and they can act in an autocrine or a paracrine way. I'm just going to let someone into the meeting. Okay, so autocrine means that the hormone acts on the cell that's released it, and paracrine means that the hormone acts on nearby cells around the cell that's released the hormone. And if you're ever writing an essay on hormones, I think it's a really nice way to start an essay by giving some definitions. So this is definitely something that you could include in the introduction. So let's start by talking about the pituitary, because that's the gland that you kind of need to know the most about. The pituitary can be divided into the anterior pituitary and the posterior pituitary. And the anterior pituitary is also known as the adenohypophysis, which you can remember because adeno and anterior both start with an A. And the posterior pituitary is also known as the neurohypophysis. In terms of embryonic development, you need to know that the anterior pituitary is formed from Rathke's pouch. And that's basically a bit of oropharyngeal ectoderm that grows upwards. And the neurohypophysis is formed from the infundibular process, which is neural ectoderm that grows downwards from the diencephalon. So there is a stage in brain development where you have 5 different sections of brain, and the diencephalon is just one of those sections. So the thing that you just need to remember is that the anterior pituitary is formed from the oropharyngeal ectoderm, and the posterior pituitary is formed from the neural ectoderm. In terms of the cell types that you have, the anterior pituitary has thyrotrophs, which secrete TSH, or thyroid stimulating hormone. It's got corticotrophs, which produce ACTH, or adenocorticotropic hormone. And it's got gonadotrophs, which produce LH, luteinizing hormone, or FSH, follicle stimulating hormone. And it has lactotrophs, which produce prolactin, and somatotrophs, which produce growth hormone. And then the posterior pituitary is made up of these magnocellular neurosecretory cells. And these cells have their cell bodies in the hypothalamus, and that's where they produce the hormones ADH and oxytocin. And they have their terminals in the posterior pituitary, and so that's where the hormones are released from. And the cell type that people always forget about in the posterior pituitary are pituocytes. And these are glial cells, basically, so they play a supporting role in the posterior pituitary. And often you're asked in essays to compare and contrast the control of the anterior and posterior pituitary. So it's important to know that the anterior pituitary receives control from the hypothalamus. And so the hypothalamus releases these stimulating hormones into hypothalamo-hypophyseal portal vessels. And those stimulating hormones travel to the pituitary, and that's where they stimulate the pituitary to release hormones. And the pituitary is also under the control of negative feedback, which we'll talk about a bit later. And some good evidence to know is that Harris in 1949 visualized blood flow from the hypothalamus to the anterior pituitary using India ink perfusion. So that's something that's quite good to mention in an essay. And in contrast, the posterior pituitary is under control directly from the hypothalamus. So you have receptors in the hypothalamus which will detect the thing that needs to be changed, and that directly affects the release of ADH and oxytocin. Okay, so let's talk about the hormones now. So this is the general scheme for any anterior pituitary hormone. So you have a stimulus, which then gets detected by the hypothalamus, and the hypothalamus releases the stimulating hormone into the hypothalamo-hypophyseal portal vessels. Those stimulating hormones act on the adenohypophysis, and the adenohypophysis releases its hormones into the bloodstream to act on an end organ. And the end organ usually releases a hormone of its own, which then acts via negative feedback to inhibit both the hypothalamus and the adenohypophysis. So let's start by talking about TSH. So if you're cold or hyperglycemic, then the hypothalamus releases TRH, or thyrotropin releasing hormone. And that leads to the production of TSH by the adenohypophysis. TSH, thyroid stimulating hormone, then stimulates the thyroid to produce T3 and T4, which are the thyroid hormones. And those act via negative feedback to inhibit TRH and TSH release. If you're ever writing an essay on TSH, a good disease to mention is Graves' disease. So that's an autoimmune disease where you produce antibodies against the TSH receptor. And when those antibodies bind to the TSH receptor, they stimulate the receptor. And that causes feelings of hotness, anxiety. You also have weight loss and exophthalmos, so that's where the eyes bulge forwards. And because TSH also stimulates the thyroid to grow, you get a larger thyroid gland, or a goiter, which you can see on the neck. So ACTH, during times of hypoglycemia or stress, the hypothalamus releases CRH, which travels via the hypothalamo-hypophyseal portal vessels to the adenohypophysis. And the adenohypophysis releases ACTH into the blood, and ACTH acts on the adrenal cortex to stimulate it to release cortisol. And again, cortisol has a negative feedback effect, and it inhibits the release of both CRH and ACTH. And when you're talking about cortisol, it's good to mention that CRH, ACTH, and cortisol are all released in a diurnal rhythm. And I remember in first year, I think this was taught quite confusingly, because so a circadian rhythm is when the release of the hormone follows a 24-hour cycle. And a diurnal rhythm is when there's more hormone during the day than at night. But what's confusing is that cortisol levels peak in the hours just before you wake up. So just because it's diurnal doesn't mean that the peak is necessarily at 12 midday. So that's something to bear in mind. And lots of the adenohypophysis hormones actually follow a diurnal rhythm, but it seems to be the cortisol one that you kind of talk about the diurnal rhythm a bit more with. And a good disease to know is Cushing's disease. So again, I used to get very confused about this, because there's Cushing's syndrome and there's Cushing's disease. And Cushing's syndrome is the collection of symptoms that you have when you have an excess of cortisol. So that would be things like truncal obesity, proximal muscle wasting, poor wound healing, osteoporosis, and also lots of other things like easy bruising as well. And Cushing's disease is when you have all these symptoms, but it's caused specifically by a corticotrophinoma, which is secreting excess ACTH. So some lung cancers, for example, can produce ectopic ACTH, and that's Cushing's syndrome, not Cushing's disease, because you don't have a corticotrophinoma. Okay, moving on to LH and FSH. GRH, or gonadotrophin releasing hormone, is produced by the hypothalamus. It travels via the hypothalamo-hypophyseal portal vessels to the adenohypophysis, which then releases LH and FSH. And these then have an effect on the ovaries and the testes. So in the ovaries, FSH stimulates follicle development, like its name suggests, and it also stimulates ovulation. And then LH stimulates progesterone production. And then in the testes, FSH stimulates spermatogenesis and LH stimulates testosterone secretion. So in the ovaries and testes, FSH and LH basically do very similar things, but it's just different germ cells that they're acting on. And again, the progesterone or testosterone that's produced will have a negative feedback effect. And if you have activating mutations in the LH receptor, then that leads to precocious puberty, which is where puberty has an onset that's much earlier than it should be. Okay, so we've used this scheme of stimulus, hypothalamus, adenohypophysis, and then end organ for all of these so far, and with negative feedback. But the exception to this rule is prolactin, because it receives an inhibitory signal from the hypothalamus. So the hypothalamus releases dopamine, which inhibits prolactin release. And prolactin normally stimulates the growth of the mammary glands and milk production. And it also causes lactational amenorrhea, which is where there's a period of infertility after giving birth. And if you have a prolactinoma, which is a pituitary tumor that's secreting excess prolactin, that can lead to galactorrhea, which means release of breast milk independent of pregnancy and giving birth. And you can also have infertility and impotence because you're inhibiting the gonads. And you can treat it with dopamine agonists like bromocriptine. Okay, and finally, growth hormone. So high levels of amino acids or other metabolites and stress, sleep, and exercise can all stimulate the release of growth hormone releasing hormone from the hypothalamus, and that stimulates the release of growth hormone from the adenohypophysis. And that in turn can stimulate growth via insulin-like growth factor 1. And people tend to just stop at growth and think growth hormone means it stimulates growth. But don't forget that growth hormone also has metabolic effects. So it increases protein synthesis and raises blood glucose. And those things have a negative feedback effect again on the hypothalamus and the adenohypophysis. And a good disease to know are gigantism and acromegaly. So if you have a pituitary tumor that's secreting excess growth hormone, then in children that leads to this thing called gigantism, where children become really, really tall. But if you're an adult and your growth plates have already fused, then there's no way that you can grow even taller. So instead, in adults, you get acromegaly, which involves having enlarged hands and feet and coarsening of the facial features. So moving on to the posterior pituitary. The posterior pituitary produces ADH and oxytocin. So ADH, or antidiuretic hormone, concentrates your urine, and you can remember that because diuresis means basically peeing and losing water. So if you're doing antidiuresis, then you're producing more concentrated urine. More concentrated urine. So osmoreceptors in the hypothalamus detect an increased osmolarity, and that leads to the release of ADH, and ADH travels in the blood and can act on V2 receptors in the kidney, and that leads to the insertion of aquaporin 2 into the collecting duct, and that in turn causes the concentration of urine. And ADH can also act on V1 receptors in the vasculature, which causes vasoconstriction, so you increase blood pressure. And a good thing to mention if you're ever talking about ADH is diabetes insipidus, which is where you produce large amounts of dilute urine because this ADH system isn't working. And you can have a cranial or a nephrogenic type. So in the cranial type, it's sometimes seen in elderly people when they have a fall, and just kind of the shock of the fall damages the pituitary stalk, which can inhibit your ability to release ADH. In the nephrogenic type, the problem's in the kidney. So a good example to remember is lithium, which is a drug used to treat depression and bipolar disorder. And lithium has quite a narrow therapeutic index, so it can quite easily damage the kidneys. And so in nephrogenic diabetes insipidus, you're able to produce ADH, but it's just not having an effect on the kidney. And it can be brought on by lots of other things as well. But a good one to remember is lithium. And there's also an animal model for diabetes insipidus. You might have heard of the Brattleboro rat. And that's a rat that has a naturally occurring mutation that means it can't produce any ADH. And these rats will produce large amounts of dilute urine, and they'll try and replace the fluid that they've lost by drinking lots as well. So that's quite an interesting example. And oxytocin has lots of different actions. So one action is the Ferguson reflex during parturition, which is where during giving birth, the baby's head pushes on the cervix, and that stimulates the release of oxytocin. And then oxytocin stimulates uterine contraction, which pushes the baby's head even harder against the cervix, and that stimulates even more oxytocin release. So that sets up a positive feedback loop. And then you also have the milk ejection reflex as well. It's involved in that, and it's also involved in social and parental behavior. And we know about these functions because oxytocin knockout mice have normal labor, but they're incapable of ejecting milk and they have impaired social recognition. So moving on to the thyroid. The thyroid hormones T3 and T4. T3 is the metabolically active form, and it's the one that increases your basal metabolic rate. And T4 needs to be converted to T3 in order to bring about an effect. And the thyroid also produces calcitonin. And I think in first year you don't need to know that much about calcitonin, but it basically reduces plasma calcium levels by reducing calcium release from the bone. And during development, the thyroid forms from the endoderm of the developing larynx, and that starts to protrude out and form the thyroid diverticulum. And as that grows, it becomes the thyroglossal duct, and the thyroid gland develops at the end of the thyroglossal duct. In terms of the vasculature, I think all you need to know is that the thyroid gland is supplied by the superior and inferior thyroid arteries, and it's drained by a venous plexus, which is formed from the superior, middle, and inferior thyroid veins. And often, I think in essays, they ask you about the structure of the thyroid, and it's really easy to just kind of talk about development, talk about the vasculature, and say, yeah, the thyroid has two lobes on either side of the trachea, joined by the isthmus, but don't forget to talk about the microscopic structure as well. So this is the diagram that I would draw. You can see that's a follicle, and the follicles are lined by a single layer of simple cuboidal epithelial cells. And in the center of each follicle, you have the substance called colloid. You also have parafollicular C cells, which are the cells that secrete calcitonin. And there's a blood vessel there to remind you that the thyroid is highly vascularized. And that's because after it's produced its hormones, it needs to release them into the bloodstream. So you have lots of blood vessels in close proximity with the follicles. If you have an excess of thyroid hormones, that leads to thyrotoxicosis, where you have heat intolerance, palpitations, and weight loss. And so what's the difference between hyperthyroidism and thyrotoxicosis? Well, thyrotoxicosis is the syndrome of all the effects of hyperthyroidism. If you have hypothyroidism or a deficiency in the thyroid hormones, then that leads to cretinism, which is where you have stunted growth and mental retardation. And if you have very severe hypothyroidism, that leads to myxedema, where you'll have low body temperature, confusion, and even difficulty breathing. And myxedema, again, is a very confusing term because not only does it mean severe hypothyroidism, but it also refers to this skin condition you can sometimes get on your legs in both hyper and hypothyroidism. So that's just something to bear in mind if you ever see that word. Okay, so talk about T3 and T4. If you're asked to describe the hormones, I kind of split it up into production and then the effects that it has. So production, first, a sodium iodide symporter on the basal membrane of follicular cells pumps iodide from the plasma into the cells. And then a thyroperoxidase on the apical membrane oxidizes iodide to iodine, and that iodine is then used to iodinate tyrosine residues in thyroglobulin, and that leads to the production of T3 and T4. And then these get released into the circulation. So T3 and T4 are bound to plasma proteins in the blood, and there's 3 that you need to know, so albumin, thymidine binding globulin, and transthyretin. And then if you remember, T3 is the metabolically active form, so we need to convert T4 to T3. And that's done in the liver by a type 1 5' deiodinase. And this also takes place in the kidney, but not as much. And so what happens if you don't need that much T3, but you have lots of T4? Well, if that happens, then you can convert the excess T4 into RT3, which is inactive, and that gets cleared by the liver. So you have quite a tight control over how much T3 you're producing. And then T3 is transported into cells and it binds to its receptor, which is a nuclear receptor. And the nuclear receptor can act on thyroid response elements in promoters. And that leads to an alteration in gene expression with the overall effect of increasing the basal metabolic rate. So some of the things that it's involved in, it will stimulate the sodium-potassium pump, and it also increases protein, carbohydrate, and lipid metabolism. So that's how it kind of increases the basal metabolic rate. And then you don't need to know much about the parathyroid glands. So very briefly, you have 4 parathyroid glands. They're in your neck, and you have 2 superior and 2 inferior parathyroids. And confusingly, during development, the inferior parathyroids come from the 3rd pharyngeal pouch, which is higher up than the 4th pharyngeal pouch. And then the superior parathyroid glands come from the 4th pharyngeal pouch. And during development, they swap places. And the parathyroid glands secrete PTH, or parathyroid hormone, in response to low plasma calcium. And they increase plasma calcium by increasing the release of calcium from the bone and increasing GI absorption of calcium from the diet. And it's good to know about PTH secreting tumors. So you can have parathyroid adenomas, which will release excess PTH, but you can also have PTH secreting ectopic, ectopic PTH coming from solid tumors, and both of those would cause hypercalcemia. Okay, so onto the adrenals. The adrenal gland looks a bit like this, and this is the diagram that I would draw in an exam. So you have the medulla on the inside, and then the cortex is divided into 3 zones, which we'll talk about in a minute. The adrenal medulla, so the central bit, develops from neural crest cells, and it contains chromaffin cells which are full of catecholamine granules, and that's how the catecholamines is stored before they're released. And if you remember back to when you learned about the nervous system, you might remember that preganglionic sympathetic nerves usually terminate on the sympathetic chain ganglia, and the exception to that rule is the thoracic preganglionic sympathetic nerves, which terminate directly onto the adrenal medulla. And those sympathetic nerves release acetylcholine, which acts on nicotinic acetylcholine receptors to stimulate the rapid release of adrenaline from catecholamine granules. And if you're talking about the adrenal medulla, you should mention pheochromocytomas, and those are tumors of the adrenal medulla. So if you have a tumor of the adrenal medulla, you're going to be releasing excess catecholamines, so excess noradrenaline and adrenaline, and that leads to hypertension, tremor, anxiety, and tachycardia. And then the adrenal cortex, in contrast, doesn't develop from the neural crest cells, but it develops from the mesoderm. And it produces steroid hormones from cholesterol. And if you're talking about the adrenal cortex, it's sometimes nice to contrast it with the adrenal medulla. So you could talk about how steroid hormones are produced from cholesterol on demand, and they're not stored, whereas the catecholamines are stored in granules in the chromaffin cells. And the steroid hormones can diffuse through the cell surface membrane because they're lipid soluble, and they act on intracellular receptors, which then diffuse into the nucleus and act to control gene transcription. And because you need transcription to take place and then translation for steroid hormones to have an effect, their effect usually takes place on the scale of hours to days, whereas the catecholamines released from the adrenal medulla will have an effect on the scale of seconds. So the layers of the adrenal cortex, the outermost layer, or the zona glomerulosa, produces mineralocorticoids like aldosterone. And aldosterone increases the salt and water content of the body, and that leads to an increase in blood pressure. I think someone else is giving a lecture on aldosterone, so I won't go into it in too much detail. And the zona fasciculata is the middle layer, and that produces glucocorticoids like cortisol, which leads to lipolysis and protein breakdown and gluconeogenesis. And finally, the innermost layer, the zona reticularis, produces small amounts of dehydroepiandrosterone, or DHEA, and normally this is just a very small proportion of the adrenal cortex secretions, but it plays more of a role during fetal development and in puberty. And a good disease to mention when you're talking about the adrenals is Addison's disease, or adrenal insufficiency. And features of Addison's disease include fatigue, weight loss, low blood pressure, and hyperpigmentation. And interestingly, the reason you get hyperpigmentation is because if you remember back to that general scheme of hormones being released from the anterior pituitary, cortisol released from the adrenal gland will have a negative feedback effect on ACTH release from the adenohypophysis. And if you're lacking that negative feedback, then you're going to be producing more ACTH. And ACTH is produced from this precursor, pre-opiomelanocortin, or POMC. And this precursor gets cleaved to form ACTH, but it also gets cleaved to form lots of other different things as well. And one of those things is melanocyte stimulating hormone, or MSH. And that's why you get hyperpigmentation as well in Addison's disease. So this is a diagram just showing the synthesis of catecholamines, and I'd really recommend learning this for exams because it saves you so much time if you can just produce this diagram instead of writing out every single step. And it's also quite easy to remember if you just remember the four chemical reactions that happen. So you have hydroxylation, decarboxylation, another hydroxylation, and methylation. And if you can remember those four things, then the names of the enzymes are quite self-explanatory as well. So just talking through this, you start with tyrosine, which gets hydroxylated to DOPA by tyrosine hydroxylase. And then DOPA gets decarboxylated by DOPA decarboxylase to produce dopamine. And dopamine gets hydroxylated by dopamine beta hydroxylase to produce noradrenaline. And noradrenaline gets methylated by PNMT to form adrenaline. And the MT of PNMT stands for methyltransferase, so that will make sense as well. And adrenaline has a whole range of different effects. And I think we might be a bit short on time, so I won't read through them all. But the general message is that it has an effect on the cardiovascular system, respiratory system, a GI system, and has an effect on metabolism as well. So it's not just increasing your heart rate. It does all of these different things, and it acts via adrenoreceptors. And I've got in there which ones cause what effect, so you can have a read of those in your own time. Okay, moving on to the pancreas. So the pancreas is a special organ because it's both an endocrine organ and an exocrine organ. In terms of its endocrine function, people normally talk about alpha and beta cells first. So the alpha cells release glucagon in times of hypoglycemia, and glucagon acts on the liver to promote glycogenolysis and gluconeogenesis. And then beta cells are found in islets of Langerhans, and they secrete insulin in response to hyperglycemia or high amino acid levels or hormones like GLP. And GLP sensitizes beta cells to glucose, so that's how it acts to increase insulin release. And insulin does the opposite of glucagon. So insulin acts by first binding to a receptor, which then stimulates autophosphorylation of the receptor. And that creates binding sites for proteins with SH2 domains. And overall, insulin promotes anabolism. So in terms of carbohydrate metabolism, it increases GLUT4 translocation into the cell surface membrane of muscle and adipose cells. And GLUT4 is a glucose channel, so it increases the uptake of glucose into those tissues. And once inside cells, the glucose then undergoes glycogenesis and glycolysis. So those are the opposite of glycogenolysis and gluconeogenesis. And in terms of protein metabolism, if you just remember that insulin promotes anabolism, it's really easy to remember that insulin increases protein synthesis, and it also increases lipogenesis and decreases lipolysis. And if you're talking about insulin, don't forget to mention diabetes. So always talk about the two types of diabetes. Type 1 is autoimmune, and it's mediated by T cells, which destroy beta cells in the pancreas. So you're producing less insulin. And then type 2 is caused by insulin resistance. So you can produce insulin, but it's just not bringing about its effects on cells. And because of the nature of type 1 and type 2 diabetes, you can treat type 1 with insulin. And with type 2, I think insulin is sometimes used as almost a last resort, but it's more likely to be treated with other drugs like metformin. And I've also put in an insuloma here, and that's a tumor of the pancreas where you produce excess insulin. And I think it's quite rare, so you don't need to know about it at all, but I thought it would be good to just mention. And then you have these other cell types as well in the pancreas. So delta cells secrete somatostatin, which has a paracrine effect by inhibiting insulin and glucagon release. And then PP cells produce pancreatic polypeptide, which decreases exocrine secretion by the pancreas and decreases gastric emptying. So it's having an overall effect of slowing down digestion. And then epsilon cells produce ghrelin, which increases hunger. So the PP cells and epsilon cells basically counteract each other's actions. And that brings us on to the gastrointestinal hormones. So the thing to know about GI hormones is that they're produced by a diffuse endocrine system. So that's in contrast to all the other endocrine organs we've discussed so far, where the endocrine cells are clustered together into glands. So in the GI tract, the endocrine cells are just dispersed throughout the tract, and they can sense the contents of the lumen and release peptide hormones by exocytosis. So let's just go through each of them in turn. So gastrin is produced by G cells in the antrum of the stomach, and its release is stimulated by gastric distension or the presence of proteins in the chyme or by vagal stimulation. And gastrin leads to pepsin and stomach acid secretion, and those have a negative feedback effect because the G cells are within the stomach itself. Once the stomach acid levels start to rise, that can be detected by the G cells, and they will reduce the amount of gastrin that they're producing. And you can have this syndrome, Zollinger-Ellison syndrome, where you have a gastrinoma, which usually isn't actually inside in the stomach. I think it's sometimes in the duodenum, possibly the pancreas. And that releases gastrin. And because it's outside of the stomach, there isn't this kind of negative feedback effect. So you end up releasing more and more stomach acid. And as a result, you're at increased risk of getting peptic ulcers. And then gastrin brings about histamine release. So histamine is released from the enterochromaffin-like cells of the stomach, or ECLs. And like I said, it's stimulated by gastrin or by vagal stimulation. And histamine has a paracrine action, and it stimulates gastric acid secretion by acting on H2 receptors. So it's kind of a two-step process where gastrin stimulates histamine release and histamine stimulates gastric acid secretion. And next you have cholecystokinin, and its action is easy to remember because anything with cholecyst means it's to do with the gallbladder, and kinin, move, so cholecystokinin secretes gallbladder contraction. And it also stimulates pancreatic enzyme secretion. And cholecystokinin is produced in the duodenum and the jejunum, and it's released in response to protein and fat products in the duodenum. Next, you have secretin, which is produced by the small bowel in response to acid in the duodenum, and it stimulates the release of bicarbonate from the pancreas and the liver to try and neutralize that excess acid. And you have ghrelin again. So ghrelin is produced in the stomach, and it's produced in response to fasting, and it increases your appetite. And then finally, peptide YY, which is produced in the small bowel in the presence of food. It inhibits feeding, so it does the opposite of ghrelin. And then the last few hormones that you need to know about, the kidney produces erythropoietin, and erythropoietin is released during times of hypoxia, and also its release is stimulated by anemia as well. And that's because when you have low oxygen levels you have high levels of this transcription factor, HIF1 alpha, or hypoxia-inducible factor. And that leads to the production of more erythropoietin. And the action of erythropoietin is to increase erythropoiesis, or red blood cell production. And you can imagine how if you have chronic kidney disease, you might have lower levels of EPO production, and that leads to anemia. And so you can treat this anemia by giving recombinant human EPO. And your syllabus also wants you to know that EPO can be abused by athletes, because if you give yourself EPO, then you'll produce more red blood cells, and that increases your endurance. And then the other hormone you need to know about in the kidney is renin. And renin's part of this renin-angiotensin-aldosterone system, which I won't go into too much detail about because I think it's in one of your physiology lectures. But the thing to know about for OB anyway is that the system increases sodium reabsorption, and water then follows in with the sodium, and that leads to an increase in blood volume and therefore blood pressure. And moving on to the heart produces atrial natriuretic peptide, and this is produced by atrial myocytes when they're stretched. So when would your atria be stretched? Well, they would be stretched if you have too much fluid inside your bloodstream. So if you have higher blood pressure, then ANP gets released, and it basically does the opposite of the renin-angiotensin-aldosterone system. So it reduces salt and water content within the body. And then final group of hormones that you need to know about are the prostaglandins. And similarly to steroids, they're produced on demand, so they're not stored, and they're produced from arachidonic acid. They have lots of different actions, so just a few of those actions. They can stimulate uterine contraction after delivery. Prostacyclin, which is one of the prostaglandins, inhibits platelet aggregation and stimulates vasodilation. And then the action that you absolutely need to know about is that prostaglandins mediate pain and inflammation. And that's really important to know because we have NSAIDs, or non-steroidal anti-inflammatory drugs, which inhibit one of the enzymes involved in producing prostaglandins. So that's this enzyme COX, or cyclooxygenase. And just some examples of NSAIDs are aspirin and ibuprofen. And something you should know is that there are two different COX enzymes, so COX-1 and COX-2. And COX-2 is the one that specifically mediates pain and inflammation, and COX-1 is ubiquitous, and it's also involved in maintaining that mucus lining of the stomach. So if you take an NSAID and it inhibits both COX enzymes, then you'll end up with less protection on the stomach. And as a result, you can get peptic ulcers, which is why some people are prescribed a PPI, or proton pump inhibitor, when they're on NSAIDs. And you can actually now get drugs that specifically inhibit COX-2, so those drugs wouldn't have the side effect of peptic ulcers. Okay, so I thought I would do some multiple choice questions as well. We've got 10 minutes, and because this is being recorded, don't worry about actually saying the answers out loud. Just kind of note them down in your head or something. Okay, so first question. Name the 5 main cell types in the anterior pituitary. So I'll give you a few seconds to do that. Okay, so I hope you've had enough time to write down your answers, but the answer is thyrotrophs, corticotrophs, gonadotrophs, lactotrophs, and somatotrophs. And if you're struggling to remember their names, You can try and remember the hormones that they produce and then work backwards because a lot of them have very similar names to the hormones that they produce. Next question. Name the main cell types in the posterior pituitary. Okay, and I hope no one forgot to mention pituocytes. So the answer was magnocellular secretory cells and pituocytes. Third question, what is the stimulus for PTH secretion? And the answer to that was low plasma calcium. And in first year, you don't actually need to know that much about PTH and calcitonin, but a good thing to remember is that they work against each other. So calcitonin will decrease plasma calcium levels and PTH will increase plasma calcium levels. And so PTH must be stimulated by low plasma calcium if it's going to be increasing plasma calcium levels. Question 4. Which hormones does the adrenal cortex produce? So for this question, just try and name the kind of broad category of hormone that gets produced by each layer if you can, and then maybe an example if you can remember. Okay, I think that's enough time, hopefully. So starting from the outermost layer, you have the zona glomerulosa, which produces mineralocorticoids. And an example of a mineralocorticoid is aldosterone. And then you have the middle layer, the zona fasciculata, which produces glucocorticoids. An example of that is cortisol. And then finally, the innermost layer, the zona reticularis, produces dehydroepiandrosterone in small amounts. Okay, last question. What are the key features of steroid hormone production and action? So this question's a bit tricky, but if you try and contrast it with catecholamines, for example, try and pick out the key features that distinguish the two from each other. Okay, so some of the things I put were that steroid hormones are synthesized from cholesterol. They're produced on demand, so they're not stored. They act on nuclear receptors because they can diffuse through the cell surface membrane. They don't need to act on cell surface receptors. And because they're acting through altering transcription, their effects take hours to days to take place. Great, so thank you very much.